Wells, anything new out there? Any new drugs coming down the pike?
There are. Most of them, I must say, the immunotherapy sort of fever continues to be very compelling to both patients and physicians, and there really are hardly any consults I do nowadays where that sort of doesn't come up. Colorectal cancer, for whatever reason, has been resistant to immunotherapy.
Non-MSI, MSS colorectal.
MSS, correct, the most common subtype. And so I'm seeing a lot of combination studies coming. I'm seeing a lot of novel agents, bispecific antibodies, antibody-drug conjugates, et cetera. However, at least in the ASCO 2018, we're not seeing anything presented that's sort of groundbreaking quite yet. We'll sort of see what happens. The trial looking at the STAT3 inhibitor ended up being a negative trial. There's this question of a phospho-STAT3, maybe picking out a subtype of patients who benefit, but always hard to know how to move that type of thing forward. And if you think about it, when has a phospho antibody really been a predictive marker reliably?
Bert, cobimetinib and atezolizumab got everybody excited with a few responses in a phase 2 study, large phase 3 international trial done. Press release reported negative, full data to come. Obviously disappointing. Should we keep pursuing these kind of combination immunotherapy approaches?
Well, I think we have to. This has been such a game changer in other types of cancer, and I think we'll eventually figure it out. So you think we'll be able to convert these cold tumors to somehow hot if we just figure out the right way to do it? Well, these things are hard to predict, right? No, we didn't predict the PD-1 antibodies just a few years ago. So I certainly think we should continue to study. We shouldn't give up on that.
How about the Nivo-Ipi data with MSI high colorectal cancer showing a nice response rate? Does this mean we should go there when we find one of those patients with metastatic MSI high colon cancer?
I currently use pembrolizumab for the MSI high patients or nivolumab. I haven't really gone to the Nivo-Ipi to CTLA-4 inhibition. I feel still that the differences are small. Again, some may argue maybe the durability of responses is better with CTLA-4 inhibition, but I also feel that the toxicities are significantly higher too. So I'm not, again, sold on to the Nivo-Ipi in colorectal cancer MSI high.
And Wells is going to put a dollar sign in front of
well,
us.
I think of it a little bit like FOLFIRINOX or FOLFOXIRI. Do you need a response, and how quickly do you need a response? So from my standpoint, given the extra 15 to 20 percentage points of response that you get when you add the CTLA-4, if a patient's symptomatic or having other issues, then I might add it on, knowing I'm probably going to get more side effects. And then if not, I think I can get away with a single agent. I think one of the interesting things about these studies in MSI high is that the response rates and the benefit have slowly dropped with each meeting. When it first was reported, this was a total miracle drug, and I must say I've seen responses in clinic I've never seen before, and I don't know when to stop. To me, that's going to be one of the interesting questions: is when can we stop these therapies? But I would say overall, in the last year, the efficacy has been tempered a little bit from what we initially saw with single agent PD-1 or PD-L1.